We are discussing complications of cirrhosis. One of the complications of cirrhosis is ascites. So we will discuss about causes of ascites, what will be the initial presentation and workup, how to take short history exam, what will be the diagnostic workup, management of ascites, what is the role of diuretics, what is diuretics resistant ascites, what are the takeaway points. Ascites is the accumulation of fluid in the peritoneal cavity. And the most common cause of ascites is cirrhosis, 80% of the cases. Let's discuss about etiology. Number one is portal hypertension. So there are different causes of portal hypertension: cirrhosis, alcoholic hepatitis, Budd-Chiari syndrome, CHF, constrictive pericarditis. Low albumin level can cause ascites. Low albumin will decrease oncotic pressure, which will result in increased hydrostatic pressure, and that can cause ascites. So low albumin can be caused by nephrotic syndrome, protein losing enteropathy. Peritoneal diseases, patients on peritoneal dialysis, malignant ascites, hemoperitoneum infections can cause ascites. Severe myxedema can cause ascites. Pancreatic ascites, which can happen because of severe pancreatitis. And illicit drug use, over-the-counter drugs, supplements can lead to ascites. So you will get the call from the ED physician and they'll give you the quick swap note and request you to admit the patient with ascites. The number one thing you should know is what is the cause of ascites. While you're talking to the ED physician, look at the vitals, look at the CBC, see if the patient is anemic, thrombocytopenia, CMP, look at all the electrolytes, kidney function. Imaging, if done currently in this ED admission or in the past, always review the past medical history. Try to find out what is the cause of ascites, and if it is because of cirrhosis, what is the cause of cirrhosis. So if the CT scan is done, this is how ascites look like. This is the liver, and around the liver, this is all ascites. This is ascites. How to take the short history. So patient will complain of abdominal pain, distension, ask about any systemic symptoms, fever, nausea, vomiting, or diarrhea. Your goal is to assess if the patient is having spontaneous bacterial peritonitis secondary to ascites, which means that see if the patient ascitic fluid is infected or not, change in baseline mental status, anasarca, orthopnea, PND, CHF, maybe the cause is CHF, hematuria, smoking urine, urinary symptoms can be present in nephrotic syndrome. Signs and symptoms of portal hypertension, which can present in cirrhosis and other causes too. Look for signs and symptoms of anemia, respiratory distress, because severe ascites can cause respiratory distress. Do the quick exam. Pain in the abdomen is one of the important signs of spontaneous bacterial peritonitis. It's also called hallmark of peritonitis. Pain in the abdomen, abdominal tenderness. Look for the drug screen, any history of IV drug abuse in the past, hepatitis panel. If the patient has change in mental status, rule out infection, you have to check urine analysis, do the chest x-ray, check ammonia level, do the imaging. You can also do bedside ultrasound, CT abdomen, MRI abdomen, see if you have any results available. One of the most important tests which we have to consider is paracentesis, which can be done in the ED or once patient is admitted to the floor. So you will look at the appearance, you will look for sag gradient. The gradient is greater than 1.1. It does not mean that patient has cirrhosis. It means that patient has portal hypertension, and the portal hypertension can be caused by different causes, and one of which is cirrhosis. Sag gradient less than 1, no portal hypertension. So if it is greater than 1.1, the causes are cirrhosis, alcoholic hepatitis, Budd-Chiari syndrome, portal vein thrombosis, CHF, constrictive pericarditis. SAG decrease with diuretic treatment but remain unchanged in patient with cirrhosis. SAG gradient less than 1.1, it means no portal hypertension, can be caused by nephrotic syndrome, protein losing enteropathy, pancreatic ascites, peritoneal carcinomatosis, serositis. So once you do paracentesis, first we look at the appearance. If the fluid is looking turbid, it means that it is infected, and the sensitivity of turbid fluid for infection is 98%, but the specificity is only 23%. But if it is looking turbid, 98% chance that it is infected. If it is looking milky, uh, think about chylous fluid, check the triglyceride level. It's most commonly related to malignancy. If it is looking bloody, common in malignancy like hepatocellular carcinoma. If it is looking brown, think about jaundice patient, especially if the bilirubin concentration is high. Also think about gallbladder rupture or perforated duodenal ulcer in the right clinical situation. You will send the ascitic fluid for cell count and differential. The most important point about cell count and differential is that you have to put the stat order for that. You have to call the lab if they fail to follow up in a timely manner, because uh, if you do not send out this order uh, at the right time, you will not be able to diagnose the infection unless the infection is too advanced. So cell count differential, you'll send it for gram stain culture, cytology for any malignant cells, TB culture, adenosine D amines level, CEA level. So you will send the fluid for protein. So protein is important. So we are looking at total protein. And if the SAG gradient is greater than 1.1, which means that patient has portal hypertension, there are a couple of causes related to portal hypertension. One is cirrhosis and the other is CHF. Both can cause portal hypertension, but in cirrhosis, the protein will be less than 2.5 gram per deciliter because liver is cirrhosed and will not produce any protein. But in CHF, with portal hypertension, the protein will be greater than 2.5 gram per deciliter. In patients with nephrotic syndrome, their protein will be greater than 2.5, but their SAG gradient will be less than 1.1. They will not have portal hypertension in patient with nephrotic syndrome. You will send it for glucose concentration, LDH, you will check in ascitic fluid and in the blood. If the amylase level is greater than 40, think about pancreatitis, bowel perforation. If the triglyceride level is high, usually greater than 200, think about chylous fluid, common in malignancy. Bilirubin concentration, if it is high, in jaundice patient, think about bowel or biliary perforation in the right clinical situation. If you are thinking about CHF, you can also check proBNP. Next is, how will you manage the patient with ascites? So once the patient develops ascites secondary to cirrhosis, as we are discussing the complication of cirrhosis, one of which is ascites. So if the ascitic fluid is because of cirrhosis, it will unlikely be resolved without treatment. It will not resolve without treatment. So treatment wise, first they have to stop drinking, salt restriction less than 2 gram per day, fluid restriction, diuretics, large volume, paracentesis, 4 to 5 liter per day. So what are the exceptions? So you should know exceptions When not to start treatment. Exception, not to start treatment. So if the ascitic fluid is because of alcoholic cirrhosis and you think that the cirrhosis can be reversible. So if you tell the patient to stop drinking, their ascitic might resolve. If the ascitic fluid is because of decompensated hepatitis B cirrhosis, ascites will resolve with antiviral treatment. If the ascitic is because of alcoholic hepatitis, then it can also resolve if the patient stop drinking. Now, what is the role of diuretic? Because diuretic is one of the most important treatments. So we will discuss the role of diuretic. So we'll start the patient on aldactone furosemide in 100 ratio 40 per day. But if the patient weight is less than 50 kg, they are at risk of developing hypertension. And in that situation, you can decrease the dose to 50 milligram of aldactone, 20 of Lasix. Now, if we compare aldactone versus furosemide, aldactone has longer half-life, and you can use it as a single dose too. Aldactone is more effective compared to loop or thiazide diuretic. So aldactone is more effective compared to loop or thiazide diuretic. What is the reason? So both loop and thiazide diuretic, they require tubular transport mechanism to be effective. So for loop and thiazide diuretic to be effective, they have to enter tubular lumen, and they are both protein bound. How they enter the tubular lumen? By secretion. And this secretory process is impaired in patient with cirrhosis because of presence of toxic metabolite. The net effect is both loop and thiazide diuretic, they will not work effectively. Their natriuretic effect will be impaired. So that's why aldactone is more effective compared to furosemide or thiazide diuretic. You can also use aldactone alone as monotherapy if patient potassium is very low. And once patient potassium is normalized, then you can add Lasix later. Why it is important? You have to avoid hypokalemia in patient with cirrhosis and ascites because if the potassium is low, it can enhance renal ammonia production, which can precipitate hepatic coma. Our goal is to maintain potassium level of greater than 3.4, but less than 5 at least. The other important thing to remember is do not treat fluid overload from cirrhosis or do not treat ascites from cirrhosis with IV Lasix like we use in heart failure. So let's say if someone has CHF and someone has cirrhosis. In CHF, they can have gut edema and oral Lasix will not work very well. That's why we prefer IV Lasix in CHF patient. But in patient with cirrhosis, they do not have gut edema. And you can use oral Lasix in these patients. And we prefer over oral Lasix because if we use IV Lasix in these patients, they are at risk of developing kidney failure. So IV Lasix should be avoided because of increased risk of kidney failure in patient with cirrhosis. The next question is how much fluid should be removed in patient with cirrhosis with ascites. So we divide it into ascites with peripheral edema, patient who have ascites with peripheral edema, and then patient who have ascites without peripheral edema. So if the patient, the goal is you can remove up to 300 to 500 ml fluid per day average, or you can decrease their weight daily by 1 kg, 1 kg every day. If you try to remove fluid, if you want to remove more fluid, let's say more fluid than half a liter, then you can try paracentesis. What are the indications to stop diuretic? If patient develop uncontrolled or recurrent encephalopathy, sodium less than 120, kidney failure, or creatinine increase greater than 2, these patients will require alternative treatment like paracentesis. Next is what is diuretic resistant ascites? So number one criteria, patient is on max dose of diuretic. Max dose of diuretics. Patient is on strict sodium restriction, less than 2 gram per day. Patient is not taking any anti-inflammatory medication, not on NSAID or other nephrotoxic medication. So while patient is following this treatment, there is no weight loss. And then rapid accumulation of ascites after paracentesis with strict sodium restriction, or if the patient developed diuretic related complication like kidney failure, hepatic encephalopathy, severe electrolyte abnormalities. This is the criteria for diuretic resistant ascites. To confirm the diagnosis, you will check urine sodium in these patients. And if the urine sodium is less than 78 milliequivalent per day with no weight loss, then patient has diuretic resistant ascites. If the patient is excreting more than 78 milliequivalent of sodium per day, this means the patient is still diuretic sensitive. Any patient who develop diuretic resistant ascites should be placed on liver transplant list. How will you manage the patient with diuretic resistant ascites? Strict sodium restriction, less than 2 gram per day. Once the patient develops diuretic resistant ascites, or once the cirrhosis is advanced, then these patients have a tendency that their blood pressure will fall because of formation of toxic metabolite. And there are studies out there that you have to keep the patient's blood pressure high in patients with cirrhosis to improve survival. So to improve the blood pressure, you should stop blood pressure medication. Any medication which decreases blood pressure, you should stop them, like ACE, ARB, NSAID, beta blocker. Stop this medication. And if the blood pressure is still low, then we should try some medication to increase their blood pressure, like midodrine. You can start with 5 milligram TID, and the maximum dose is 17.5 TID. And your goal for MAP should be greater than 82 millimeter of Hg. So like I said, survival in patients with cirrhosis and ascites is dependent on MAP. So any patient with blood pressure greater than 82 millimeter of Hg, they have 70% chances of surviving 2 years. Whereas patient whose MAP is less than 82, they have only 20% chance of survival at 2 years based on studies. Now let's say if the initial treatment fails, then and patient have diuretic resistant ascites, then the only option is serial paracentesis. And the goal is remove 8 liter every 2 weeks. So whenever you remove the fluid, you can use albumin, especially if you are removing greater than 5 gram, 5 liter. If you are removing more than 5 liter, then you can use albumin, 6 to 8 gram per liter. Albumin is sometimes expensive, and if it is not available, then you can also use midodrine. If patient cannot tolerate paracentesis with diuretic resistant ascites, then the last option is TIPS. What are the takeaway points? Ascites is the accumulation of fluid in the peritoneal cavity. The number one test in patient with ascites, the number one test you will consider is paracentesis, and you will calculate SAG gradient. It's not a ratio, SAG gradient. And if it is greater than 1.1, it means patient has portal hypertension. If it is less than 1.1, no portal hypertension. So portal hypertension, different causes. Important one, cirrhosis, CHF, constrictive pericarditis, Budd-Chiari syndrome. No portal hypertension, think about nephrotic syndrome, protein losing enteropathy, peritoneal carcinomatosis. But the idea of SAG gradient is you are assessing if the patient has portal hypertension or not. What kind of treatment available? Stop drinking, salt restriction less than 2 gram per day, diuretic, starting dose aldactone, Lasix combination, starting dose is 100:40. Assess if the patient has diuretic resistant ascites if needed. If the patient is not responding to max dose of diuretic, patient is on fluid restriction, patient is on sodium restriction, patient is having diuretic complication. If the patient is meeting the criteria, you should know the criteria of diuretic resistant ascites. Check urine sodium level. If the patient has diuretic resistant ascites, patient need to be placed on liver transplant list. And then the only option left is paracentesis. So this is the summary of ascites, which is one of the complication of liver cirrhosis. Thank you very much. Have a nice day.